Hello, everyone, and welcome back to our clinical corner. Today we are focusing in on 24-hour care and that person-centered approach to care. So this is our third installment to our clinical corner, which is quite exciting. And today you'll notice a few new faces, which we're delighted to have on. My name is Nicola Murphy, and I'm an occupational therapist working here in Accora. Before we kick off, though, just wanted to say that this is going to be an interactive session as usual. We will have a Mentimeter that's going to come up soon, so QR code. So we do encourage everyone to scan that for your engagement. And then any questions, please feel free to pop them in the chat and we can answer them throughout the session. And then in a moment, we will just introduce all of our roles in Accora and our experience. But I did want to ask everyone out there, tell us in the chat where you're from, where you're linking in from today, and maybe what department you work in and the role. Are you an OT? Are you a physio? Are you a nurse, tissue viability nurse, a speech and language therapist? Tell us where you're coming from. So yes, my name is Nicola and I'm an OT. And so my experience comes from working within the NHS. I've done all my rotations within the NHS. I've been out in the community doing some work, been in surgeon vascular, been in the wheelchair services, and then prior to becoming an OT, I was a social care practitioner. So I did a lot of work within a dementia unit. So I'm hoping that I bring lots of great examples today to discuss and think about what person-centered care means to me. So I'll hand over now to Jayne, and then we'll work around. And again, if you want to introduce yourself.
Thank you. Hi, everybody. My name's Jayne Brewer, and I'm an occupational therapist too. My background has been within the NHS, but mainly as a community occupational therapist. So I think when you're out in the community, you see how people are really functioning with their day-to-day tasks, and you can sometimes really be quite person-centered. You get a nice range of experience. And then I left the NHS to join Millbrook Healthcare, one of our equipment providers, as a clinical lead, working in that service, training up prescribers on how to prescribe equipment appropriately. Lots of recycling of equipment, and then I left there to join Accora, and I've been with Accora 3 years now. So I have a lovely role like you, Nicola. We go around and train a lot of the OT, so probably met some of you that are on here today around sort of the clinical benefits of the product. So yeah, it's been really good. Keep my hand in, clinical hand in, do some seating assessments, things like that. So
yeah, great,
fantastic. My name's Sarah Thompson, and I'm a tissue viability nurse. My background has been mainly in the community, which is where I was before joining Accora, but also in the acute sector, and seeing people within the hospital and the community is very, very different, especially when you're talking pressure ulcer prevention. In the hospital, people are more likely to go with what we kind of suggest, whereas the community, we're going into people's houses. So hopefully we can discuss more about that and how I see patient-centered care as well.
Brilliant. Our two new faces here now today, which we're really excited about. Typically out on the road, product specialists. But yeah, tell us who you guys are.
Yeah, I'm Tom. I'm a product specialist. I'm also a registered physiotherapist. So a background doing lots of different things, from infection control to working in public health, child weight management programs, and also elite sport as well. Sort of that's taken on my current role now as, like Nicola said, a product specialist, primarily in southeast of England. So anything south of the River Thames, really, all the way down to Brighton.
I say it's a good side, the south of the river. Once you go north of the river, you're stuck in traffic. Yeah.
Hello, my name is Dean Curson. I'm also a product specialist and physiotherapist. However, I'm just transitioning into a clinical product trainer role. So like Jayne, Sarah, and Nicola, I'll be coming out and doing some of your training with chairs and beds and so on and so forth. I do have quite an extensive history prior to being a physiotherapist in the health and fitness industry. So I spent most of my time there doing consultations, teaching people how to change their lifestyles for the better. So I'm hoping I can lean on those skills a little bit to kind of explore how that can be implemented into patient-centered care today, and obviously some other relevant experience.
Brilliant, thank you. great. We're coming from all different areas, aren't we, today? But I can see in the chat as well, there was some people come from Tower Hamlets. So maybe, Tom, you're probably going to contact. I think there's someone from Ireland as well. So it's great to see everyone kind of contributing to the chat. So please do continue that. So as we move on, we will be asking everyone here, what does person-centered care mean to you all? But I hope my little colleague in the background is going to bring up a QR code now, and if everyone can just scan that and tell us, what does person-centered care mean to you? Maybe a case example or a situation where you found that it was a really good scenario that was truly person-centered care, but also tell us some examples of what maybe is not person-centered care, and that'd be great, and we can definitely discuss them as well. So I'm going to hand it over to everyone here now as well. Who's going to shout out? I suppose, tell me a scenario. Who wants to say that that you found is really person-centered care, or maybe a client that stands out to you that you found that, yeah, I did my 100% best and I was, really focused on that holistic approach, person-centered approach. Who wants to go first? Go on, Jayne.
I'll put my hand up. I'll go first. I think for me, person-centered care is really thinking about that individual and what activities are meaningful for that individual. Because I think as OTs, we do tend to concentrate on, can that person get washed and dressed? Can they transfer? Things like that. And sometimes for some people, that's not their priority. Getting washed and dressed isn't their be all and end all. I've worked with people especially I used to work in an intermediate care unit, and we were always looking to get that person discharged home, and can they get washed and dressed? Can they walk down the corridor? Can they get in and out of bed? But I remember one gentleman, it was more important to him that he was able to get back into his garden and do a bit of gardening. It didn't matter that someone was helping him to get washed and dressed. He wanted his energy to go out and do that task. So I think, it's just spending time with people and finding out, what's meaningful activities for them, and not just try and fit them into the things that we think that they should be able to do.
Absolutely.
And it's kind of that it comes in onto that goal setting, doesn't it? Because we might set these goals, but these smart goals, but actually, are they person-centered? Is this actually the goal that is meaningful for that person?
Exactly.
We say, they need to get back to an independent wash and dress, but actually, what is the end goal? Is it that they need to get up out of bed to achieve that, to then get back into the garden, right?
I think that's where our roles can work quite closely together. Whereas, yes, the end goal is that person wants to get back out into the garden, but as an OT, I'm going to look at any access problems. As a physio, you're going to look at maybe building up his muscle strength, aren't you, so that he can walk down the corridor and get over that step and out into the garden. Can he bend and
things absolutely.
Like that?
It's funny you mentioned gardens. I think that's actually quite a common goal for a lot of people. Because gardens, if you've got green thumbs, right, being out of the garden is like you're detoxing. And I remember a particular case where I was out in the community, and this lady had recurrent falls, and she became fearful of accessing the garden. It wasn't necessarily she didn't want to be there, she just had this mental block of getting out there. So that was obviously the priority, and we had to work around her mobility and access to make sure it's safe. So an MDT approach was really useful in that scenario. But also with that lady, I remember we were going there, and she had bicep tendonitis, right? And we were kind of going through the diagnosis process, trying to figure out what her was causing her pain. And it turns out it was actually because her mobility had declined. She was sitting a lot more, and one of her pastimes was reading, and she loved reading. And being in this fixed position for so long was causing her tendons, and from the way she was mobilizing her crutches to cause that. So yes, I wanted to address to manage the symptoms, but we had to work around how I don't want to take away your reading. This is obviously something you're really, really passionate about. So we have to think of creative ways to.
That's where us as OTs would come along.
I was just going to say, was there no team involved?
We would adapt it and get her a nice book stand or something like that she could,
And in that scenario, was there an OT involved?
No, there wasn't. There was not at that point.
So you had your OT hat on and your physio hat on.
Yeah, I mean, my solutions at that point probably weren't as clever as yours with your skill set. Like I said, this is where I could have improved really on my person-centered care, because I identified it, but this is probably going to be a recurring theme that everyone's going to share, is you're still there with your objective, and mine was to manage those symptoms and to rehabilitate her, but it was at the back of my mind, and that's probably where I could have done better of making it more of a priority when I communicate with her.
Yeah. And I think that's when, you know, I'm OT, right? So you guys are physios, CVN, Jayne OT. Then it's about, well, let's get all the other disciplines, let's get the other experts, let's get the MDT involved to actually have that more of a holistic, person-centered approach. And because if that lady was sitting quite a lot, I'm sure then, Sarah, you would have been like, how long is she sitting?
Absolutely.
You know?
Yeah, and especially in this role, we want to do more on prevention. But with like my knowledge, sometimes you can kind of see something's going to happen to the skin. But I think when you're talking about pressure ulcers, if somebody has a pressure ulcer, it's then you have got that goal. You do need to heal that pressure ulcer ideally. So as a TVN, you go in with that hat on to heal that wound. And we need to heal it as soon as possible, because the longer a wound stays around, the more problems you get, the more potential for infection. So actually, we do have that goal, but for somebody who I wouldn't then say, right, okay, we need to get you to bed, and then they lose their function for everything. So there is a lot to think about when somebody has a pressure ulcer, because that is the goal. We do need to heal it, but we need the help of that person. And so we go through all the they do in their everyday lives. They still have a life to live, where a young man was actually told he got a pressure ulcer, and he was told bed rest, and he was on bed rest for 4 years. And then you think,
shared
not the recent one. No, this is one I literally just heard of the other day. And you know, that's a young man, and we're essentially putting him to bed.
Disabling.
Completely disabling.
Well, you think about in the media, you hear about all the effects of COVID-19 and socially the impact that's had. And you can all relate to being isolated. Now, to them, it's probably even more so, because they're confined to a room, not even a house. And during your developmental years, if we're talking about kids and the impacts having on their education and all that, so there is a huge knock-on effect that you need to be considered when you're, like you're saying, when you're making a decision like that. There's a massive gravitas to that.
Definitely.
But I think it's again like thinking about what activities are important for that person. So if you go back to Jayne's case studies, how could we enable that person that we'd encourage to go to bed still carry on reading in that environment? What positioning can we do so that they can still manage to read but still keep off that pressure ulcer, but still have some functions and just, you know, participation and things.
There's always that those decisions to have, and you can always have that compromise. I often one of my cases was a chap with MND, and when I actually went out to visit him, I found out he was sitting from 8 o'clock in the morning to 8 o'clock at night. There was no changes in positioning at all. So we just talked through things, and actually sleeping wise, he was on an alternating mattress and a tilting platform. So actually at night that was fine, but we needed to come up with some changes, let's say, or solutions during the day. And we worked out he would have a siesta after lunch a couple of days. He'd have a lay-in a couple of days. Obviously we have to work that with carers as well, you know, paid carers, they come in at certain times. So it's just having those discussions really.
As a team.
MPT,
not going in our little silos. I think that's what happens. I know in the community sometimes, you know, you've got one team going in to do this and another team to do something else, and you never have that conversation.
Joint work.
And you're all working and pulling in different directions sometimes.
And sometimes it just makes it that choice is hard. Right? Sometimes it's popped in, what does person-centered care mean to them? So hi, whoever this was, but individualized and tailored. So Sarah, when you mentioned about the carers and that person getting up at a particular time, that in the community, that was just such a common theme. If they're coming in too early, I like to sleep in. So then maybe it's with the OT actually tailoring that care plan, going back to that care agency to communicate that. So often we have to advocate for our clients, right, to make sure that it's going to work for them. Because if they don't like to get up at 7 o'clock in the morning, it means they're not going to be able to participate and engage in meaningful activities.
And it's their life.
It's their life. Yeah.
How would we like it?
Yeah. So it's about advocating, isn't it?
Yeah.
And making sure that it's going to work for that individual person.
Definitely.
I love that we just got straight into gardening because I love gardening and I have such green fingers. I take after my mother. She loves her gardening too. But I always remember when I worked in the care home and as a social care practitioner. So my role was to get people engaged and participate in activities throughout the day and make their day meaningful. And often I would put on bingo, I would do their nails, get their hair done, like just all these different activities, arts and crafts. And it's just not every task or activity would suit everyone. But gardening was the very one that everyone, I had all of them out in the garden. We were sowing sunflowers, and actually it was just a great way of getting people participating and engaged. And they just, they loved it. And often that older generation, it kind of brings them back, isn't it?
One case I think about a lot, we were obviously asked to think about cases before we come on here today, and it's exactly one about that. But it was a younger lady who I was seeing in our community rehab team, and she'd had a stroke, and we did lots of work. You used to get the putty out and people, didn't you, and the cone to try and get her hand function back. And I said to her, what do you really want to do? And she said, well, before I had my stroke, I had a window box and it's still not planted. No one's gone and planted it.
Oh.
And, her stroke was obviously quite sudden and obviously that was bothering her more than anything, really. So I just went and got some plants and we got the box out and we just practiced like holding on to the plants and putting them in the soil. We were doing the same movements with her hand, but just making it more person-centered for her and meaningful for her. Thank God that's done. That's been weighing on my mind. I think she had greater problems than her window box. What happened.
Yeah. And I'm going to add on to that because often with physios, you might plan, get some exercises going, and sometimes people just don't engage in them because it's a bit boring, or I'm guilty of it.
Very common.
I've been doing it,
very common.
and I don't really commit to the exercise after a while. But if it's something that's meaningful and actually I see purpose in it, then I'll engage in it. So for this lady, it was interactive. It was something that was and good for her, and she was still doing those same movements. So she's actually doing her exercises.
And I think sometimes you get quite rigid in our role, and sometimes you just have to go a little bit above and beyond. It was like I had to go and get the compost, I had to go and get the flowers and all stuff like that. But
you loved it though, didn't you?
Yeah, I did. I thought I'm really being an OT here. But we sometimes get a bit stuck in our role sometimes, don't we?
We do.
We're not allowed to go out of our boundaries. I mean, we're very lucky in where we work now, but I appreciate some of the people out there are quite have to work within their boundaries, don't they?
And I suppose on that point, is there, so far we've just been chatting about what is good looks like, but actually then let's flip on his head and maybe what does not so good look like.
Well, that actually triggered a memory of where I could have improved my person-centered care. Talking about gardens again.
Yeah.
And the reason it didn't spring to mind is because...
Is it because it's summer?
maybe.
And it's a really nice day.
It was complete oversight on my behalf. I was in a neuro rehab unit and this lady had a stroke similar to your patient. And we would, like you said, doing exercises, probably a little bit boring, admittedly, but necessary. And the stroke had affected her temperament. She was lashing out quite a lot. And we did a home visit. And one of the things that she was particularly annoyed about was the state of her garden it had got in because she couldn't tend to it. And had I thought about it, I could have implemented some of those sort of activities into my rehab with her. I could have thought, all right, you like gardening, maybe you can get your fix and your satisfy that need in a therapeutic way. So it's about taking in that information, not just seeing it as its own issue. Like, oh, that's a home problem. No, it's a personal thing.
And that leans into someone's point here is hear a voice and advocate. So I know we were chatting before this as well, and I'm actually listening to that person and what is it that they want, you know? Maybe it's their communication of how we communicate our interventions or implement different activities and exercise plans. So here's some points. And there's so many examples I could bring up with that one. Sarah?
I've got a really good one with when it comes to pressure ulcer prevention and we're trying to prevent or we're trying to heal pressure ulcers will quite easily go, right, well, we need to change your mattress, for example. And I remember one case, this was years ago, and this is a very common thing, I should think. And this guy got the mattress. They're not always very comfortable, but the two things that really, really got to him was the noise of the mattress and the fact that it vibrated on the end of the bed, and he could not sleep. And he was just like, take this mattress away. And we hear that quite often. So the fact that you can't sleep and you've got this constant irritation, they're two minor things really that we can talk about. But to someone who is in that bed, it's massive, massive, massive. And yes, we need some kind of therapy, but actually a nurse or, somebody could easily come away and say, patient refused mattress. Because with pressure ulcers, it's very much a blame culture. We've created this blame culture, and it really, really shouldn't be. Instead of saying the patient, we're blaming the patient because we don't want to get blamed for that person getting a pressure ulcer. But what we need to do is look into, when we investigate pressure ulcers, look into what can we learn from them, not who can we blame.
I love that example. Yeah, that's really amazing. And again, it's about having that clinical overview as well. And because when you're talking about the sleep, I was thinking some people might go straight in, okay, well, we need to look at sleep hygiene and how can we get him to sleep better on that mattress. But no, it's the mattress, it's the noise, it's the vibration. Listen to the person. If it's not working, then for this person, how do we make it better for them? As opposed to trying, fixing it. Let's look at this and digest.
And there's other ways. There's other ways that, you don't have to have the mattress that's noisy and vibrates. There are other ways. Let's educate that patient and let's, come to some kind of agreement how we can get that pressure ulcer healed. There is other ways. There's so many different tools.
And I think, it is listening to that patient. Someone needed to listen to him and find out what that problem is.
Not patient refuse.
That's not really listening to people, isn't it? And hearing what they're saying, what they're trying to tell you, and giving them that time to tell you, because sometimes the patient is the best expert on their condition, isn't it? Not only think about what they want to achieve, but how is life for them? I think you were saying earlier about trying to step into someone's shoes, isn't it? Just trying to think, what does it feel like for that patient? It's like when we do seating training, I'm so, come on everybody, come and sit in the chairs. I want you to know what it feels like to sit in one of our chairs, so that you know what it feels like when you go and do that seating assessment. You can sort of, appreciate that your patient doesn't, what they feel, appreciate what they feel. And
we say that a lot in our training. It's only when you can't move you actually realise how uncomfortable it is to be in one position. It really doesn't take long to.
I always go back to the example of sitting on a 12-hour flight, right, or a long plane, and or like on a train and you're stuck in the corner. Recently I was in a train and there was no window, so I was like, I'm not happy here. Sitting for that long period. But I know, Tom, you and I were prepping before this session and we were like, oh well, what is person-centered mean to us? And we were going back to, I suppose, the example of, well, what does it mean to that, the person? So I had a question there, I suppose, how do you balance what someone wants with what's clinically right? So I always go back to the statement, you and I did a webinar recently, sleep and advised recliner. I know I keep going back to this, you're probably actually talking about it again. But unconditional positive regard. So it might not be what we think is right, but actually what that person thinks is right? And going what they want, because we might say, well, we need this, but it's not going to suit them. It's about making sure that they're comfortable, they feel safe, they feel secure, and they can engage in meaningful occupations.
You can work towards goals, can't you? I had one other case where there was this isn't pressure ulcers, but this is leg ulcers, and we really needed to get her back to bed. She was sleeping in her rise recliner, so technically pressure ulcers as well. And she didn't want a bed brought downstairs in the living room, and I was trying to unpick what was going on, and it turned out her husband died in a profiling bed in that room, and so she then thought, okay, if I get that bed and it's downstairs, you know, it was just too close.
That would be the journey.
Yeah.
Too close to home. And yeah, that's like such a valid point, because you know, people are seeing their family, friends in those scenarios, and it can be quite traumatic for someone, right? So it's about, again, listening to them, hearing their voice. And someone else put down personalization. So, you know, making it person-centered, right? Focus on the person.
It's so obvious, like on a weekly basis, especially when you're like the time constraints of half an hour revisit, which you're often under. Not one person's condition is the same. And sometimes you're going in thinking, okay, let's just solve this posture, right? This is what we need to do. X, Y, and Z. But at the end of the day, you might get to the end of that and then think, well, what can you do what you want to do? Can you watch your TV? Can you still do your knitting? Is it going to allow you to do that? So it's very easy to just, okay, you've got a short period of time, you're under time constraint, I need to solve this, this, and this. It's like setting the goals at the start and finding out what they want to achieve and working around that.
For sure. Funny you mentioned knitting as well, because I remember being out with one of our other product specialists, Chris, and we had this lady, and we need to review the seating and make sure positioning was much better and posture was much better. But her main goal was to continue her knitting. She was advanced stages of Parkinson's as well, so she wasn't doing perfect knitting, but it was her what she liked to engage and what she found meaningful. And once we set everything up and corrected everything, then she couldn't reach to get her knitting to the side. So we were like, oh, hold on now, we need to fix this. So then we adapted the environment so that she could continue to do that knitting. So we just raised the table up and made it better for her. So it was meaningful and person-centered.
I wanted to just add something, what you said earlier on about what's clinically right and what they want and how do you balance the two. And I think it's important to use the word validation, because it's one thing to hear what someone says and to listen to it, but it's also another thing to validate their feelings. Because when we're talking about the bed earlier on, it being noisy, I think, right, put myself in their shoes. I personally hate having crumbs in the bed. Now, if someone told me there's no choice, you have to sleep with crumbs in the bed, no, that is completely unreasonable. And I would expect someone to turn around and be like, yeah, Dean, get up and brush them off. Or, you know, we'll do something differently. And if you're not validating that person's feelings, even though, in this hypothetical analogy, crumbs are good for me for whatever reason, you're going to lose a relationship. You're going to resent that person who's forcing you to do something that you don't want to do. There has to be a middle ground. And I think that is the ultimate goal of person-centered care within a clinical capacity. You've got your objective goal, right? We've got a job to do at the end of the day, but you're not a plumber going into someone's house fixing a machine. You're dealing with an individual who has a subjective experience. So it's about developing that rapport by validating them. So they go, do you know what? You are listening to me. You get it with empathy. Now I'm going to come a little bit towards you and believe what you're saying is in my best interest, because you're not just telling me what to do. You're empowering me to be involved in that decision-making process.
And sometimes it's going back, you know, it's being open and honest. Sometimes you say, look, unfortunately, there's nothing I can do. I can't get the crumbs out of your bed. I'm going to be totally honest with you. I can't get rid of them. But maybe like, what could we do together? How could we work together to make it a better situation for you?
Is it actually about looking at that routine as well? And, you know, I would go to, you're eating your food in the bed. Well, let's look at another setup that we could do, maybe getting out of bed for meal times. But again, it's going back to like unconditional positive regards. And actually, listening to that person and making sure that they feel heard. And, you know, again, we were chatting before, and it was thinking about someone's decision making. So some people might have unwise decisions, and we might not agree with that, but you know, we have to be non-judgmental in our approach. So it's and working with them.
I think it's important as well. I think, Dean, you might have said this earlier, it's really important for us to put ourselves into people's position, which is really quite hard actually when you think about it, because we don't know what it's like to not move. But, you know, when we wiggle, when we're uncomfortable, we wiggle. It is really hard, but I think it's important to try our best to be in their shoes.
I'll echo that as well, because especially if you're dealing with the UK, right? It's a very diverse population, ages, cultures, generally just experiences. So how do you contend with trying to relate to someone who you may not have same walk of life at all? And that is about being, I think it was you, Sarah, was talking of Mike, being clinically curious.
Yes.
Right?
Yeah, like
So
that.
be curious, be interested in people.
Yeah. Ask why.
Yeah.
Lots.
Why,
You've got to enjoy speaking to people.
Yeah.
Ask it why.
Yeah.
Yeah. Yeah.
Unpick the layers.
I like
Find
that. It's
out.
like unpicking the onion.
Yeah. Yeah. There's so many layers. So many.
Clinicians are like ogres. We have layers.
Well, it's like when anyone phones me for advice, I will literally ask like 101 questions, and I apologize for it, but I need to know all this information, and then with one question there's a layer to that, because I need to understand
The picture.
the whole picture.
Yeah.
And I think that's what the person-centered care is having that holistic view of that person, not just the task that you're going in to do, all those other factors that make up that person and why they're doing the things the way they do. You know, in the community, you go into so many different environments like you guys do, and you think, how is this person living this way? But that's the way they've chosen to live.
On
and it's
that,
being non-judgmental, isn't it?
absolutely. Yeah. And how would we like it if someone came into our environment and said, you got to do this?
Yeah, yeah.
Like, no, you're in my house.
Yeah.
I'll do what I want to do.
That's right. And I think for those people as well who maybe don't live in their own house anymore, they're in care homes and things like that. Sometimes you question yourself how person-centered that is. Meal times are a protected time, aren't they?
Yeah.
And lunch times are a protected time, and then everybody's expected to go to the lounge for dinner. Is that really person-centered in these care homes and things like that?
Yeah. On that one as well, I remember while I was working in the care home, and there was a particular gent. He was quite a young man, I think like in his 60s, and still quite mobile. And in a care home, often people don't get to get out much, right? And he didn't have much family support, so I knew that he liked to exercise and go down to the local little pond where there was some ducks. So I was like, every day at 2 o'clock, we went out, well, when he wanted to, of course. We went for a nice walk, and actually, they contributed to other people getting involved, and they wanted to participate as well. So, yeah, it's about listening to that person, what is going to be good for them. You won't believe it, guys, but we're already chatting for like 40 minutes.
No.
Have there been any questions?
I was just going to ask, so if anyone has any kind of good examples, please feel free to pop them into the chat. We would love to discuss them as well here. I will say again, we are talking about a lot of good, but I'm going to maybe give, as I say, flip it on its head and say maybe poor examples, or examples where it's been challenging to be person-centered. And I will always say my NHS experience of, you always have the pressures and demands on the bed capacity and the red alert, black alert. We don't have beds, we need to discharge patients. And I suppose there's always that scenario of you get that pressure on getting your clients discharged quickly, and then interventions sometimes are at that end stages, and that day before, day of discharge, we need to see them. And in a way, that sometimes frustrated me that I couldn't be fully holistic and totally person-centered to actually listen and hear that person and what they need.
I think that the systems that we work in can prevent us from being totally person-centered.
It's like I said at the beginning, when you're in a hospital, I think the feedback you get from patients is very much, oh yes, I'll do this, yes, I'll do that, because they're out of their own environment. But you then transfer that to their own home, and that's their own home. So they've then got that. We need to be more, patient-centered, really.
Absolutely. I think it's even like, you think of like video services. How many of them are offering appointments that are outside of the working day, so that people who they've got musculoskeletal injuries, they're still able to work, but they can't get to an appointment because they're working. Yeah. We then say to them, well, you've got to stop working, come to an appointment. If we have longer hours, they could come before work or after work. Can we make our services much more
And it's like a similar approach to sort of not to,
give you this.
I need to sort of speak into it, not to like drill the sort of evidence base, but you were talking about the sort of flower box at the start and doing your rehab. Someone's more likely to engage in the rehab if it's something they enjoy doing.
Yeah.
So making it tailored to them, and I guess you could sort of do that for person-centered as well. We're looking at maybe posture, pressure care and things like that. But they're more likely to engage in those things if they can do the things they enjoy while they're utilising the air cushions, the lateral supports, etc.
Yeah, definitely.
It's doing it at a time that is convenient for them.
Yeah.
You know, if you've arranged your seating assessment at 9 o'clock in the morning, but that person doesn't like to get up till 12 or
And they like their
something,
siestas.
and they don't, they don't get up till 12. They're not going to be susceptible to that assessment when we turn up at 9 o'clock in the morning, are they? Can we arrange our days so we can do it when they're up and maybe more amenable to it?
And not to suit us, but we actually have to hear our patients and making sure that it is because we all have demands as well when we're out in that community. We might have a lot of people on our caseload, but it's about if we're going to work with them, they'll work with us, and then we get the best out of that intervention.
Getting that therapeutic relationship.
Yeah, for sure. I always go back. I just wanted to example of a client that I seen while I was working in the wheelchair services, and I will always remember this client because we built a very strong therapeutic relationship. And I remember when he first came in to me, he came from the transport, and he walked from the reception all the way down to the clinical room, and it was like probably about 100 meters. And then 6 weeks later, he came back in, and then he had a walking. I think it might have been a crutch, and then he had a 4-wheel walker. So every time I saw him, he was progressing more and more with his condition. And I got to the stage then we need to get him a wheelchair, a powered wheelchair. And unfortunately, he was living in a first floor flat with no lift access. So it meant because of the systems, we couldn't actually issue it. So I went out and advocated for him, went to the MND Society, and we managed to fund him an electric chair. And for me, I was just like, I'm being a real OT here, because all he wanted to do was go to the pub, play cards with his friends, and he could do that. And then when he came back for a review of his electric wheelchair, he was like, oh, yeah, I've been to Poland. I was like, been to Poland?
Opened the world up for him, literally.
Because before he couldn't, because his mobility was so poor. And actually, it was a scenario where he didn't have a very good relationship with his family. So we enabled him to go and build that relationship with his family again in Poland. And I'll always remember that scenario. He got into the pub, he got his pint, he played cards, and he got on a flight. Like that's
it's sort of like a buzzword, but like I don't know if anyone's even said it, but it's just resonated, like advocating for them on like what they enjoy. It's sort of drilled into you, but it actually is so important to do in that person-centered care.
Yeah, definitely.
I found a document actually in a bit of research for this by the Royal College of OT. They've actually got a document out called "Making Person-Centred Care a Reality." So it highlights how we can, help shape services, advocate people to make person-centred care a reality. Because it should be what we all do. We shouldn't really be thinking about it. We should be doing it as part of our course. And it's saying about really to focus on people's strengths. And also to sort of balance in their choice, but also with that element of risk. So if we allow people to have free choice, sometimes they're going to make risky decisions. And how can we balance that level of risk? So that's like with your pressure ulcers. Yeah, it's how can we maintain people's occupations, and how can we keep people connected with their families, their friends, keep them connected in the community, because a lot of people, become very isolated, don't they? So that's, if anybody's interested in that, I think Emily's going to put the link in the chat, but it's quite a good document to say, how can we make it a reality by working in those areas.
I think on that note, if somebody had a pressure ulcer, so we obviously nurse lots of people with pressure ulcers, and sometimes that pressure ulcer healing isn't their utmost priority, but we have to give that education to say, okay, let's try and do what we can do, but it might be that pressure ulcer is going to be with you longer or may not heal at all. it's weighing all that up, and that's really difficult when they've actually got a pressure ulcer.
It is difficult. Like, it's difficult for us as well.
Yeah.
The amount of times you're in someone's house and you think, this is what you need to stop this pressure. This is what you need to sit correctly.
Unconditional
This is what you
positive
need.
regard.
But it's like, right, remind yourself. Okay, it's not what they want, but it can be difficult. You think this is what you need, but
Yeah. And it's about them. It's rational to them. It's irrational to us. But it's rational to them because it works, right?
Yeah. And I think it's
That might not be
frustrating.
wise.
It's frustrating for us sometimes because we know what they need.
Yeah.
But if we just want to do our best for people, don't we?
Yeah.
So we can maybe not have that patient-centered care because we want to do our best. But
you've got to tread lightly with that, because I have seen in many cases where what you think is best is being imposed on the patient or service user. And going back to what I was saying earlier on, if you do that, and I'm guilty of doing this in some regard, I'm not accusing anyone at all. But if, let's say, you went down that road of you need this, you're doing it. And I have seen it a couple of times. You tarnish that relationship, okay? And then no progress is made. So even if your intentions are, this will help you, well, now you can't get through to them at all. You've completely lost them. So sometimes having a little bit of an impact is better than having no impact at all.
Yeah, definitely. I do talk about that in first of all. I keep going back to the wheelchair services, but I remember the lady, and I was quite new to wheelchairs as well, and I was working with the engineer, and we were like, okay, this lady needs to have tilt. She needs tilt because she had like a grade 4 pressure sore, but she was still using self-propelling wheelchair. But without even thinking, we were putting her into a tilt-and-space chair. It would actually disable her because then she couldn't self-propel. And then we really had to drag ourselves back in, and we got another colleague involved, and she was like, no, wrong decision. She needs to be still independent and get about the day, right? So we can go and try to fix it, but actually, being holistic, taking into account that person.
Getting everyone around the table.
You've got your own but maybe is it best if I speak with this group of colleagues as well? Give me different ideas. Actually, it's going to help. And
if you think about it, all of us as a speciality, we all look at things with different eyes. And then you've got that patient as well. So we all need to get around.
Needs to be in the centre, don't they? We're all around the outside. Sometimes our opinions will overlap. Sometimes they clash, don't they? Sometimes.
Well, something you might want to do as OTs, like keep people in a chair functional. I might say, but I want them to move, and then the patient might say,
what does the patient want?
Yeah, exactly.
Yeah, and it's important to make sure that we're having those conversations between us as well, because let's say you've had that conversation with the patient, I think it's best to go to bed. And then you have a separate conversation and say, I think it's best you have this function. We go, this is the best thing if we want to strengthen you. And they go, I'm getting contradicting information.
Yes, 100%.
What do I do? It will confuse them. And they're like, are you not even talking to each other?
That's very true.
That's something that we can be quite guilty of as an MDT. We supply our services, but if we're not communicating, are we all singing from the same hymn sheet?
I mean, you're lucky if you work in that. I'm lucky I've worked in environments where we've all been on site the whole MDT, so you have those weekly conversations, don't you? And the end goal is for this person to actually go home, but what am I going to do from my end to enable that? What are you doing? So we're working to that end goal. But if you're out in different teams, you do end up crossing paths and you don't see each other. You're all working to separate goals, aren't you? For that person.
And sometimes it's that challenge, isn't it? Because we all have lots going on, right? Isn't it? And we might not have sometimes that time to be able to reach out. But I think it's good to reflect, isn't it, on our practices and what has gone really good, and in the scenarios that I've given, I know that maybe looking back I'd probably change my approach, or focusing a little bit more on that person and hearing them.
I can remember just reading recently, I was in doing an assessment in a care home, and they'd asked us to come in because this lady had her own riser recline chair, but her condition had deteriorated. She had a neurological condition, and that was deteriorating quite rapidly, and that chair was no longer suitable because it didn't have tilt and space. There was her own riser recliner. She had how to operate it, and she was able to put her leg back to that. So I did the assessment, popped her into the advanced chair, and her posture was so much better. And everybody was like, oh gosh, she looks really good. She looks so much better. And the lady just looked at me, her speech was going as well. And she just said, where's my control?
Yeah.
And I was like, well, I've given you a manual chair. And I was like, oh my gosh, now I've taken you out of your chair that you've had for years. Now you can't change your position. I mean, luckily, I was able to ask for funding to get that chair powered and everything. And it was upgraded. But for that moment in time, I'd taken away everything, really. And I just not really thought what mattered to her was that she could just put her legs up and down, really. That's basically the only function she had left. And you just kind of think, oh gosh,
because you're trying to fix the posture, well, not fix it, but improve the posture, and reduce the risk of pressure sores.
Exactly.
She looks great, brilliant. We've done a good job, but actually,
it's just the way she just put her hand out to me, and I was like, oh, I want to control. You just get so caught up in it sometimes. You're guilty of not.
I go back to that gentleman with the MND, and we got him the powered chair, and he would come back every few weeks for reviews because he just had a very progressive MND, and it came down to the controller, so that the joystick on it, his dexterity was getting worse and worse. So he was struggling then to control the power chair. So it was about adapting it and improving for him.
And it's when that choice then could become a risk, isn't it? Then it's then getting back.
That's it. Yeah.
There was something I wanted to touch on. It ties in kind of to what you were saying, Jayne, about like reflecting, on your practice. From that, you probably learned, all right, I won't make that mistake again.
Yeah.
If given an electric controller. And Tom and I off camera were saying in this sort of person-centered care approach, the only way you're going to really know whether or not you're doing a good job is self-reflection, which we all do reflections. But it's probably worth communicating with them, if possible, about what is your experience throughout this, not just objectively, like, can you walk, can you not, can you talk? Just, are you happy? What would you like different? And involve them in your reflection process of person-centered care. And then lastly, was about hear their voice. One thing I made a note on before this is in care homes, the people that have like dementia or they've lacked capacity, how do you hear their voice? Because they can't speak, or maybe they've lost the ability to speak. And I love it when I go in care homes and they've got my story on the wall or about me. Read that, or if their family are present, ask a little bit about them. Or if there's no family present and there's carers that are long-standing carers, get to know your patient through third-party people. Just because
or get them involved, get the family member involved. To give them that reassurance and confidence.
Because I've had a couple of patients that really need the soothing voice of their husband or wife or someone. And that, because what I'm saying is fine, but they know how to communicate with them in a better way than me. So maybe it's taking the onus off yourself and involving other people.
Especially in like the acute settings as well. People coming in unwell, maybe they're just disorientated, post-op delirium and things like that. But for your interventions and assessments on the ward, they might not engage so well. So we often do try to get the family members in as well. That you're smiling, do you?
I am smiling because you just triggered a memory. I did a chair assessment not too long ago, and the husband was Irish. So your accent triggered a memory. And I haven't been to Ireland, but what I do know is you love a good sing-song. Okay? And his wife,
one up for me.
his wife was really drowsy and not very responsive, and he knew a particular song to sing to her, and he tried again, and eventually she started singing and rousing and becoming more involved. And it was such a real great example of person-centered care. Because he knows her, he knows what songs would trigger her memories. She started like diddly do. It was really cute little Irish rhyme.
Maybe it's just the Irish people, because I remember working in the care home, and I was somewhat telling you the story earlier. There was a gentleman who had quite, again, in stages mentioned that communication-wise, he wasn't able to communicate so well, and he was quite a tall gentleman, and some people, I suppose, found it quite challenging or difficult to do the personal care and things like that. And he found himself quite challenging because there was a lot of female workers. So, having a female coming in to do personal care, washing and dressing, and often he sometimes would maybe lash out. And so my person-centered approach was to have a sing-song with him because he always loved to sing. And I was on my way to the office today. I was trying to record the song. I was like, what is it? And it was.
Sing it for us now.
Come on. You've got an audience. Go on. Live audience.
Yeah,
You just start.
only 6 minutes left, guys.
You might get the rest last.
But it was,
people might log off.
under the bridges with me in Paris or something like that. But I will always forget. And I just as I was reflecting, I was like, God, it got me a bit emotional because actually I enabled him to then just feel safe, secure, and do like a task that we take for granted, right? He wouldn't shave for days on end. So I was just like, come on, John, let's get this done, and just continue to sing along with him. But yeah, he was happy and felt secure. Yeah, but I won't sing a song.
No,
Maybe if
next time.
Words. Next time. You better come back.
Join us next time.
Nicola.
Any song requests?
Put it in the chat if you've got any songs that you'd like us to sing.
We do only have a few minutes left, but if anyone has any last points or comments, please pop them in the chat. And I just want to put it out to everyone else, was their last thought.
Well, someone says they think it's a great interactive sing-along.
Would be great interactive sing-along. Victoria, can we on-mic Victoria, please?
Go on, Victoria.
Where's Victoria calling from? She's definitely Irish. Mar. Sorry.
Sorry, we digressed a bit there.
Bit much, yeah. Sarah, you're any last points or comments on person-centered care? Or maybe moving forward, what will you think about when you next see your patient who's for seating or for bed positioning?
What would I be thinking? I think it's just spending a bit more with that time with that person. I mean, we are very fortunate in this role that we do probably have a little bit more time with people. And, really finding out, what do they want to get out of when they're by the chair that they may be getting? What do they want to get out of it? And, what does it mean to them? What do they need to achieve when they're sitting?
Be clinically curious.
Love it.
Yeah, definitely.
Ask why.
I mean, like as product specialists, it is difficult because we don't know these people.
Yeah.
So it's trying to turn up in that half an hour or hour. And hopefully that the OT's got that relationship already, but finding out at the start of the session, what are we trying to achieve? What are your goals? And going through that way. But it is difficult when you're fresh to meet people.
Yeah. Yours is about the onion, isn't it?
The onion. Hitting up the leg. No, actually, as we were talking, I thought, and this is going to be my takeaway, is you've got to be a bit kind to yourself, because when you get into this profession, it's usually because you care about people. Okay, and the system, unfortunately, at the moment is under a lot of pressure, and you will be under a lot of pressure, and you may not have as much time as you'd like to get to know these people. You can only do your best. So as long as you know that you are doing your best, you are reflecting with them and yourself, you can't do any more. But as long as this is in the center of what you do, you're doing a good job. So be kind to yourself.
I like that. And try and make the patient the expert. They know about their condition.
Yeah,
exactly.
And on that, I would say I step into their world. Yeah. With that gent, I stepped into his world and I sung a song.
And Victoria is actually Irish.
Go on, Victoria.
So I think that's right.
Yeah, that's brilliant.
Beaming.
Everyone, it's been amazing again for our third episode into our Clinical Corner podcast. We really enjoy these sessions, so please, spread the word, tell everyone about our podcast. And if you have any kind of exciting topics that you would like to for us to explore, please let us know. You will get a little feedback pop up after this. And please fill that out. We really appreciate feedback from these sessions. I see something else popping up.
So
here
about singing.
Thank you for your relaxed, informative session. Yeah, okay. So, but I think the singing should be in the next agenda for the next podcast. And thank you for the words of wisdom. We all need to be kinder to ourselves and others. There you are.
That's a really nice thing.
Yeah.
Done, isn't it?
Thank you, Victoria.
Yeah, thank you, Victoria.
Brilliant again session, guys, and hopefully Tom and Dean, we will have you back
If you're
come back?
happy, as long as my voice isn't too
If you can
monotone for
bring
everyone
the
to listen
guitar
to.
and you can bring some instrument, I'll sing.
Yeah.
Bring the energy next time.
And Victoria will bring you too.
Yeah.
Thank you everyone so much for joining, and we hope to have you back again soon. Bye-bye.
Bye-bye.
Bye.